I debated Dr. Rodriguez from Mount Sinai, also in the U.S. to New York, about basically if you have to choose a bispecific antibody, which one should you choose first? A BCMA bispecific antibody, for example, Teclistamab, elranatamab, hopefully soon linvoseltamab, versus a GPRC5D bispecific, for example, Talquetamab. And obviously, my disclaimer, right? In real life, it depends on the patient. Everyone's situations are unique, and these debates are largely meant to illustrate principles and not come to a firm conclusion for every single patient. That being said, I think I made a good case for using Talquetamab first, for GPRC5D bispecifics first, on three fronts. One, I think on the efficacy front, it's worth noting, and I've noticed this in my own practice, that Talquetamab works. If you look at the Monumental-1 study, 70% overall response rate, overall survival is often easily over 2 years. It's worth noting that, because partially this is because Tal1, was studied later than the other drugs, we've had a chance to look at Monumental-1 in T cell redirection exposed patients or BCMA exposed patients. It still seems to work quite well in those patients, which is nice. So on the efficacy front, I think there's no doubt that Talquetamab works very well. The safety obviously was a big topic and will remain a big topic. I think it's worth noting that the biggest takeaway I can tell to anyone listening to this is the way that Talquetamab was dosed in Monumental-1, the way that Talquetamab is dosed in the year 2024 will look nothing like how it's dosed in 2026 and onwards, because we've gotten better at realizing that we can actually de-escalate the dose profile that actually helps a lot with some of these toxicities. For example, the dysgeusia, nail toxicity, and so forth. Dr. Chari presented an oral last year at ASH in 2023 showing that same topic, and I'll actually have a poster specifically about real-world usage of Talquetamab in the year since its approval, and we're already seeing patients go down to every 3-week dosing, every 4-week dosing. And again, at least from Dr. Chari's data, you're able to maintain PFS with that. It's worth noting that, obviously with Talquetamab, the first thought everyone has is, tongue toxicities, taste toxicities, nail and skin toxicities, understandably so. But it's also worth noting that what it doesn't have is that much of an infectious profile. But with the BCMA bispecific, that is the Achilles heel of every single BCMA bispecific. And we're still trying to figure out how best to use IVIG. What do we do for vaccinations? How do we prevent COVID infections, which were a leading cause of death on many of those studies? With Talquetamab, you don't really see that because normal B cells don't express GPRC5D. And so if you look at some of these studies, actually, B cells actually went up with time with Talquetamab treatment. You don't see that with the BCMA bispecific. Similarly, Dr. Vaghi Dolaria presented last year the TRIM2 data with Talquetamab and daratumumab. So even double therapy, still, again, you don't see that much immunoparesis. You don't see that many infections. You don't see that much B cell depletion for the long haul. And that's important to remember in terms of safety profile. And finally, I think the biggest point I made was the versatility that, I actually use a soccer analogy, or as the rest of the world would say, a football analogy, to demonstrate that Talquetamab is a team player. You can combine it with just about anything. We, for example, at our center have been using Talquetamab as holding therapy to get people to T cell collection for CAR T and gotten them to use it as bridging therapy as well. So Talquetamab, as far as we can tell, obviously not randomized data, doesn't appear to interfere with CAR T cell efficacy. And certainly, again, Talquetamab targets GPRC5D. CAR T commercial targets BCMA, so it works nicely there. We've seen data, and we'll see data about Tal plus Pom, for example. I mentioned TRIM2 with Talquetamab plus Dara, and I think largely because the infectious profile is not so bad with Talquetamab, you can combine it with just about anything or sequence it in just about any permutation that you'd like. And so, I think still, I agree that probably most of the world is using BCMA therapies before they use GPRC5D therapies. And I get it. That's a natural evolution of the field, the same way that we tend to use CD38 before we use BCMA therapies in myeloma in general. However, I think I'll end with a quote. I can't take credit for this. It's a quote by Dr. Costa, and I mentioned him, Luciano Costa from UAB in Alabama. And he phrased it well. He always says the only place where BCMA has to come before GPRC5D is the dictionary. In real world, with the patient sitting in front of you, do what makes the most sense for them. And I would argue that there's no law that BCMA has to be given to a patient who hasn't received a T cell redirector before, because again, Talquetamab definitely efficacious. The safety we can modulate in terms of the tongue and nail toxicities, infectious toxicity is not so bad. And again, it is the most team player drug I think I've ever seen in this class in terms of working with POM, with DARA, with BCMA CAR T, etc.